Hi, my name is Shellen Lee, and today I will be discussing orthopedic procedures, specifically the lumbar spine. The lumbar spine exam is considered to be one of the top 5 radiographic procedures where the staff at UNC facilities are most often making errors, either from positioning, patient safety, or image quality malfunctions. This learning module will explain how to thoroughly and successfully complete a lumbar spine radiographic exam in order to avoid these types of errors. First, let's cover the basics of lumbar spine radiography, such as the different IR sizes used, as well as various protocols executed at different facilities. Depending on what structure you're trying to visualize, the size of the IR depends on that. For example, if you're trying to capture a clear view of the L spine, you would use a 14 by 17 inch IR in lengthwise position, making sure to collimate closer to the spine to decrease scatter, which reduces image contrast. However, scoliosis is a fairly common pathology in which the spine may be curvy, so you'll have to keep that in mind when collimating in order to not clip off any pertinent anatomy, such as the spine itself. If you're trying to visualize a certain joint, such as the lumbosacral joint, a 10 by 12 inch IR in lengthwise position with open collimation to include the SI joints as well would be appropriate. The lumbar spine protocol also varies with different healthcare facilities, so you'll have to keep that in mind when you're rotating between different healthcare facilities. UNC Ambulatory Care Center, UNC Imaging Center, and UNC Carolina Point 2 Orthopedics are the clinical sites I was assigned to work at for my orthopedics rotation. These are all outpatient clinics where most patients are able to freely walk and talk. Thus, the imaging protocols used at these facilities are fairly similar, such as having the patient standing upright for a lot of the exams, but there are still a couple nuances. However, UNC Hospital would require a lot of the same exams to be performed either having the patient in supine position or using other special devices for trauma patients and immobile inpatients. This is the standard protocol for most healthcare facilities. It includes an antero-posterior projection, an AP oblique projection, either RPO or LPO, a lateral projection, and lastly, a lateral L5-S1 spot projection. Postero-anterior projections can replace the antero-posterior projections as well as the PA obliques replacing AP obliques. However, PA projections are less common than AP projections because AP projections are typically more comfortable for the patient. There's also a scepter distance between the L spine and the IR. The only benefits from performing PA projections rather than AP would be that there is less gonadal radiation dose and clear open disc spaces from the X-ray beams almost being parallel with the intervertebral disc spaces. Some facilities perform an AP axial projection of the L5-S1 joint called the Ferguson method instead of a lateral spot view. It really depends on which clinical site you work at on whether you perform a lateral spot view or Ferguson view. For the AP projection, you'll have the patient supine on their back on the radiographic table or standing upright with their back against the wall bucky for weight-bearing methods. Again, this depends on the protocol of the facility you work at. The picture on the left shows the patient in supine position. If it's possible, ask the patient to bend their knees because that will reduce the lordotic curve of the L spine and bring it closer to the IR. Plus also, it's more comfortable for the patient. Use a 48-inch SID and a perpendicular central ray pointing to the mid-sagittal plane at the level of the iliac crest. Of course, remember to have the X-ray tube detented with the central ray centered on the IR. Collimate down near towards the spine, but be mindful if the patient has scoliosis or not. The picture on the right shows a lumbar spine with scoliosis, and you can clearly see the curvy structure of the spine. You want to get all of the L spine on your image and not clip off anything, so make sure to be careful with collimation on patients with scoliosis. Repeats can occur if you do not get the optimal image of the L spine. For example, here's a checklist of the anatomy you must be able to visualize. Open intervertebral joints, SI joints equidistant from the vertebral column, transverse processes, vertebral bodies, pedicles, spinous processes centered within the vertebral bodies. If this checklist was not met, then you will most likely need to repeat the image. But if it's still captured what the radiologist originally wanted to see, then you can save the patient from another exposure by calling the radiologist first and making sure if any more images are even necessary. Also, it could be that there was some motion due to the patient breathing heavily or artifacts such as zippers or coins in the pants pocket that got in the way. So you want to make sure that there's no artifacts and give the patient clear breathing instructions. For AP oblique projections, you'll have the patient rotate their body about 30 to 60 degrees. Typically, it's going to be right around 45 degrees. And you're going to have the central ray be perpendicular to the IR and entering about 1.5 inches above the iliac crest and 2 inches medial from the elevated ACES. The picture on the left shows the patient in supine LPO position and his right knee flexed and left knee extended to support himself in the oblique position. However, if the patient is not able to support himself, the image on the right shows a spinal wedge sponge that can be used as an immobilization device to tuck under the patient's side to hold him in an oblique position. You'll be using a 44-inch SID and make sure that your central ray is centered to the IR. So why might you end up repeating an AP oblique image? The purpose of the obliques is to demonstrate the zygapophyseal joints. The RPO position demonstrates the right zygapophyseal joints and vice versa. Thus, the joints closest to the IR are demonstrated depending on LPO or RPO position. The key point as to determining whether a repeat image is necessary or not is to find the Scotty dog symbol on the radiograph. The dotted line on the spine of the radiograph shown is the Scotty dog. To make things a little more easier to visualize, I'll just give you some helpful pointers. The ear is the superior articular process, the nose is the transverse process, and the eye is the pedicle. The collar/neck would be the pars inticularis, leg would be the inferior articular process, and the body would be the lamina. Technologists can often lead to repeats on this exam if the patient is over-rotated or under-rotated. One helpful advice would be to take a look at the placement of the pedicle on the vertebral body. If it's too anterior to the vertebral body, then the patient is not rotated enough. If it is too posterior to the vertebral body, then the patient is rotated too much. Alright, for the lateral projection, have the patient lie down on their left side with their knees bent and arms up and out of the way. Of course, this can be done with the patient standing upright with their left side touching the wall bucky with their arms out of the way in front of the body. The central ray is going to be perpendicular to the IR and entering at the level of the iliac crest along the mid-coronal plane. You can move the patient's hip and shoulders either forwards or backwards to get the spine to straightly align. One helpful tip would be to place a lead shield behind the patient's back to absorb excess scatter that could degrade the image contrast. SID is going to be 40 inches and the central ray must be centered to the IR. Lateral lumbar spine radiographs can be repeated often due to image processing errors. Since the lateral projection requires the X-rays to go through more density of soft tissue, it is likely to have a grayer image with decreased contrast. For example, you might want to decrease KVP and increase mass to improve image contrast. However, if you have more soft tissue to penetrate, you cannot decrease KVP too much, so you must be efficient in setting the appropriate exposure technique for lateral L-spine radiographs. This is another reason why placing a lead shield behind the patient's back could help with reducing the amount of scatter on an image. Important anatomical checkpoints to determine whether or not to repeat the image would be open intervertebral disc spaces, open and round intervertebral foramina, borders of the vertebral bodies should be superimposed, meaning that the spine was parallel to the IR. And the spinous processes should be seen in profile, and you should have almost superimposed iliac crests. Lastly, the setup for the L5-S1 spot view, which is the left image, is similar to the lateral view, except the central ray is going to be angled cephalic or caudal depending on the interiliac plane. The central ray is going to be angled caudal if the upper iliac crest is more superior than the lower crest, and the central ray is going to be angled cephalic if the upper iliac crest is more inferior to the lower crest. If the interiliac plane is perpendicular to the IR, the central ray will also be perpendicular. A general rule would be to angle the central ray about 5 degrees caudal for male patients and 8 degrees for females. The central ray is going to enter about 1.5 inches below the iliac crest and about 2 inches behind the ACEs. The Ferguson method is shown on the image on the right, and the patient position is similar to an AP view, except the central ray is angled 30 to 35 degrees cephalic and enters about 1.5 inches above the pubic symphysis on the mid-sagittal plane. For the SWOT view shown on the left image, you should see open L5-S1 joint space. The joint should be centered, and the iliac crest should be superimposed if the central ray is not angled. For the Ferguson view, which is shown on the right image, you should see an open L5-S1 intervertebral disc space, and the SI joints must be penetrated. Here are some non-routine lumbar spine procedures that are performed when they are specifically ordered by the physician. You have the lateral hyperflexion and hyperextension, as well as the AP right and left bending images, which are done following spinal fusions. You also have the PA projection that's weight-bearing, meaning that the patient will be standing upright in order to evaluate the intervertebral disc spaces. And you also have the thoracolumbar spine protocol, which evaluates scoliosis. The scoliosis procedure is the only exam I've observed at my clinical sites. They also have their own way of performing the exam, and I will go into further detail in later slides. The lateral view can be done with the patient in hyperflexion and hyperextension positions. The pair of images on the left show hyperflexion where the patient is bending his back forwards, bringing his knees and shoulders closer together. The pair of images on the right show hyperextension where the patient is bending his back backwards, arching his back pretty much. These hyperflexion and hyperextension lateral views should contain the same anatomy as the regular lateral views, and they should use the same techniques and equipment setup as well. The AP right and left bending images are useful after the spinal fusions for patients. The image below shows the patient in AP bending right position and the patient is supine. However, I have yet seen this exam performed at the clinical sites that I have worked at. The PA weight-bearing view is done when the patient is standing upright and their front side is up against the wall bucky. They then bend either to the right or left side. The image on the slide shows the patient bending right. Also, I have yet to see this procedure done at my clinical sites. Scoliosis is also a common pathology seen in patients who come in for lumbar spine radiographs, and scoliosis may be caused by disease, surgery, trauma, or it could be idiopathic. PA or AP and lateral upright or recumbent and bending or not bending images. Basically, you can do all sorts of images with scoliosis patients. Because the exposure is taken of the entire spine and there's variations in thickness from the C-spine to L-spine, compensating filters may be used. And they are used at UNC CP2 Ortho, UNC Ambulatory Care Center, as well as UNC Imaging Center. And for shielding, breast shields and gonadal shields are used. And you have two 14 by 17 inch digital IRs that can be interlocked in a 14 by 34 inch plate. And basically the imaging software stitches or merges the two images together and makes one complete image appear on the monitor. There are other non-routine lumbar spine exams such as hyperflexion and hyperextension, which can be done lateral or AP, PA projection or weight-bearing method for evaluating intervertebral disc spaces, and there's also the thoracolumbar spine to observe scoliosis. But I won't get into too much detail into these exams because the focus is on the standard protocols at most facilities. Thank you for tuning in to this learning module.